Okay, everybody, I think we're ready to get started. Hope you guys got your fill of coffee and snacks out there. To reiterate what we talked about earlier, please stick around till the end. We've got a keynote speaker who's fantastic, and I've already seen really good slides and really meaningful, helpful stuff. So I hope you decide to stay with us till the end. So we're going to start the debates section of this. This is a fun exercise in how well I can convince people that my point is better than a national leader here. So we will try to do that. For the debates, a couple of interesting things. So we've got 4 debates. I think your program had said 5, but there will be 4 debates. We're going to do polling just for interest. So we'll poll, ask the question at the beginning, give you guys a few minutes to use poll everywhere and answer yes or no, pro or con, and then we'll see if that changes by the end of our discussions. So that'll be the approach. So maybe why don't I do the introductions, Kyle, and then I'll have you do the poll if that sounds okay. So I'll be doing, so our first debate is combination biologic therapy ready for prime time? And I'm going to be taking the con, that it's not ready for prime time. But I wanted to introduce our keynote speaker who will be speaking at 5 with his presentation, Dr. Singh, who's associate professor of medicine in the division of gastroenterology, with an adjunct appointment in the division of biomedical informatics at UCSD. He's the director of the IBD Center and the director of the IBD Clinical Trials Unit, and that's just the beginning of his biography. I will expand on that as we get to the keynote. But he will be taking the pro part of combination biologic therapy, that it is ready for prime time. So, Kyle, if we can get the survey up. And folks, it should probably have a pretty straightforward interface, I assume. Well, people are voting already. Is that true? Are you guys seeing anything that you can vote on? We hadn't troubleshooted this. Shot this?
That was predetermined.
Look at this. Come on, guys. All right, I think maybe we'll stop there. So I've got some work to do, but a lot of you think that biologic therapy, combination therapy is ready for prime time. So without further ado, Dr. Singh.
Thank you so much, Kian, and thank you so much for the kind invitation for this wonderful conference. This job is easy. For those of you who have seen Indian matchmaking, this is bread and butter for me at this point, so I don't know why Kian is even trying. So for this one, I'll play Seema Auntie from Mumbai, the top Indian matchmaker, and I'll make a case, a very compelling 3-point argument as to why I think combination therapy is ready for prime time. These are my conflicts. None of them are relevant here because most of it is not active at this point. So 3 points. The first point, why I think combination therapy is the right way to go is we've hit a therapeutic ceiling in IBD. We've been dealing with new medications. We've been fortunate that over the last 5-7 years, we have multiple different classes of medications being available now. But the reality is, even our best of medications, the rates of achieving clinical remission on top of placebo is around 30 to 40%. So the vast majority of our patients actually do not achieve remission with existing therapy, at least not in a timely manner. This holds true both for Crohn's disease and for ulcerative colitis. This holds true regardless of which mechanism of action you look at. And in all fairness, the oldest mechanism of action, the TNF-alpha antagonists, have provided us the biggest bang for our buck to date, and that was 25 years ago. We've made some progress. I'll talk about that in the talk at 5 o'clock with JAK1 inhibitors, but overall, the rate of improvement or the rate of achieving remission for our patients has plateaued. One way to overcome this therapeutic ceiling is with rational combination therapy. I'm deliberate in calling this rational. We recognize that a lot of our mechanisms of action are distinct from each other. Some of them are overlapping, others may be more synergistic or complementary with each other. So in general, if you think about this, 2 broad mechanisms of action, if you were to think about, one of them is targeting intracellular signaling pathways, and that's the JAK inhibitor pathway, the interleukin-12 / interleukin-23 pathway, as well as TNF-alpha antagonists. The JAK pathway and the interleukin-23 pathway are what we call JAK-dependent pathways, and the TNF pathway is JAK-independent. And overall, on the other side of it are the medications that are involved in targeting lymphocyte trafficking. So they just don't let the lymphocytes that are driving inflammation into the gut, and that's where the anti-integrins come in, and more recently the S1P modulators, where they sequester lymphocytes in the lymph nodes. So broadly speaking, these are the two classes of medications to think about, and these can be combined in different shapes and forms. So thinking about this, trying to combine an anti-TNF medication, which is targeting intracellular signaling, with a medication which blocks lymphocyte targeting, is sort of a complementary or a synergistic process of trying to address inflammation. On the other hand, trying to combine a JAK inhibitor with a TNF alpha antagonist or an interleukin-23 antagonist with a TNF alpha antagonist is providing a complementary is providing a synergistic effect in targeting pathways of inflammation. So rationally, it makes sense. They're targeting different pathways of inflammation, some of which are somewhat overlapping, others are not. And we have a proof of concept clinical trial that recently was published, wrong side, which was the VEGA trial. This was a phase 2A pilot study in patients with moderate to severe ulcerative colitis, combining an anti-TNF agent, which is golimumab, with an interleukin-23 antagonist, which is guselkumab. And what we observed here is we are breaking the barriers that we have historically seen. So in general, if you look at clinical response rate at week 12, rates of achieving clinical response was consistently higher with the combination of these two medications rather than each of them alone. Roughly 80% of patients on the combination therapy achieved clinical improvement at the end of 12 weeks. Rates of achieving clinical remission were 37% compared to around 20-odd% with each of these medications independently. I will confess that golimumab would not have been my preferred agent going into this. So you can imagine if the combination was with infliximab combined with guselkumab, you could have expected higher rates of achieving remission. And if we were to be thinking about things even more than a JAK inhibitor combined with infliximab would probably offer a significantly higher rate of achieving remission. And the third point is rational combination therapy is safe. That is the biggest argument that I'm sure Kian will put forward is we don't know whether it's safe or not. Before the onset of this clinical trial, there's been plenty of retrospective data, chart review studies, systematic reviews associated with that part, which have demonstrated that the combination of two medications done in a multi-drug refractory patient population still offers reasonable safety profile. So rates of serious adverse events was around 7% in the systematic review of 10 studies, close to around 300-odd patients. Rates of infections were around 20%. And if you start looking at clinical trials and overall rates of any infection in clinical trials, those rates are probably close to 20%. The rates of serious infections are much lower. So overall, it seems that the combination of two medications in a patient population that has historically been very refractory, which is what these retrospective studies were. So in general, most of the retrospective studies included patients who had failed one mechanism by itself, second mechanism by itself, and then the provider decided to combine those medications, and they still achieved improvement in symptoms, endoscopic response, without too bad of a safety profile. Imagine doing it in somebody who is treatment naive, who has not been exposed to those medications. We are much more likely to observe high rates of achieving remission and without compromising the safety profile. We know these exist in oncology where there's been tremendous success with all of these approaches. So I'll stop there. Why do I keep pressing? And we have my case is we have hit a therapeutic ceiling. We know that rational combination therapy works. We know that it is reasonably safe. My prediction would be ultimately my efforts are meaningless if the stars are not aligned. And I think the stars here are the insurance companies which need to come together in allowing and facilitating something like this. I will yield my time.
Okay, well, that was a great argument. It's pretty convincing. You will see that a lot of my initial slides basically reinforce some of the things that were said, that were very appropriately said, and I think he basically talked about these my punchline, which is the biggest issue with this plan, Dr. Singh. So yeah, I think combining two different mechanisms is an attractive option for the management of IBD, right? We've got all these different mechanisms, and I think it makes a lot of sense. What do we know? What's interesting is we have some patients that have strict primary non-response to agents that target a specific pathway. So clearly, this suggests that we have heterogeneous diseases we're dealing with here, right? So we can't predict if a patient's a TNF pathway or a different pathway that might be util. So I do think there's some role to sort of combining therapy to optimize, it might seem attractive to do that. The other issue is partial responders, right? Patients who have improvement in clinical symptoms, perhaps biomarkers, perhaps endoscopic impression, but aren't having the complete healing or the complete normalization of some of these biomarkers. I think that's attractive there. And it's ideal to target a couple of different mechanisms. We've got a number to choose from to improve our chance of success. And it's reasonable, so it's really reasonable to think that dual mechanisms could be helpful. I would agree. I mean, we've got some evidence, right? We've got, if we talk about sonic and UC success, while we generally talk about immunomodulators sort of maybe perhaps augmenting the TNF, there may be some additional role that the immunomodulator is playing to result in improvement in those studies. So for all intents and purposes, I think the intention is very good and it's very attractive. So we only have one randomized study. I mentioned this in my earlier talk. We really only have one randomized study that addresses dual biologic therapy. And this was a 2007 study with 79 patients who'd been on infliximab for Crohn's disease and had continued symptoms after 10 weeks. And so they randomized that group to continue infliximab with the regular every 8-week infusions or add natalizumab, an agent that was the primary anti-integrin available at that time. So they gave 3 infusions of the anti-integrin, and then they assessed how patients did. And how did patients do? Well, in this randomized controlled trial, using CDAI, so a clinical score as a timeline, basically the infliximab alone or the natalizumab and infliximab did not reach statistical significance as far as a meaningful benefit. If you looked at a population that had elevated CRP to begin with, so maybe this wasn't just an IBS population, but also active inflammation, maybe a little bit better in terms of things, but the only randomized study that we have really does not show significant benefit here. So then, as Dr. Singh points out, the remaining evidence comes from retrospective cohort studies, case reports, and case series, and this is from that same publication in 21. So these studies typically have less than 20 patients. There are exceptions, but it makes my case better to say typically they have less than 20 patients, because they do. Typical follow-up is less than 12 months, right? And the observations are, infection may be slightly increased in some of these, but again, we don't have a control arm, and no other real signals were seen here. What I would say is I think these studies are going to be really hard to interpret, and I think Dr. Singh would be the first to admit it. I think he actually wrote a really great paper that talked about how to look at data and different levels of evidence, particularly in perhaps therapeutic drug monitoring and other modalities. But I think that we have to recognize that a lot of these studies do have small numbers of patients. There's no control arm. The duration of follow-up is relatively short. And so a few observations. Azathioprine first made in 1957, the Crohn's studies in 1979, hepatosplenic T-cell lymphoma noted in the 90s and 2000s, right? And I'm trying to just sort of make a point here that, we really need reasonable follow-up, long-term studies that sort of tell us what happens in that cohort. Infliximab, 1997, melanoma risk noted in the mid to late 2000s. Natalizumab approved in 2004. So after a year or so, they recognized PML. And then JAK inhibitors were approved for rheumatology in 2012, but the thrombosis risk came about in 2019, right? So my point in saying all this is I do think that the most important point here is safety. And I think we just do not have demonstrated safety. And I'm hopeful that we get larger studies. I know there's a lot of dual combination studies that are coming out. It's exciting to sort of see if they will have some longer follow-up, long-term follow-up. But I do think that safety is an important issue here. And I think the other thing that's an important issue is something that Dr. Singh very nicely pointed out, which is cost is one, right? So we have to recognize that it's not just insurance companies making our lives hard, but the cost to the system, without sort of clear benefit, demonstrated cost is going to be potentially something that we have to talk about. And then the last is sort of something on the provider level, which is the struggles to get this approved, right? That's a big deal. And so if you've got, an extraintestinal manifestation and you can get a buy-in from your rheumatologist to prescribe one of the therapies as you prescribe the other, that would be ideal. But more often than not, my success has been that within a few months, the denial is there, and it takes a pretty significant act to be able to get that approved. And again, I think I don't have a lot of evidence to fight that with. I cite the same paper. So I think, to me, combination therapy is not ready for prime time. It's attractive to combine mechanisms. They have a synergistic effect. The risk of infection may be captured in short-term follow-up, but we really need longer studies to be able to tell us about the risk long-term. And so that's that. All right. Anything to add in one more minute before we poll?
I probably changed my mind.
I like that.
It is ready for prime time. I had to make a case.
So, yeah, I guess we can, do you want to put this up here, or? I won't be hurt if it doesn't change anything. I already told you at the beginning that one of the techniques to refractory Crohn's is combination biologic therapy. My talk earlier already. Oh, wow. Perfect. All right, so Dr. Singh convinced people, so you should stick to your first ones. Great, thanks. Appreciate it, Dr. Singh.
Thank you.
Perfect. All right, so that was our first one. Thank you guys for voting. All right, so we're going to shift gears here a little bit. For the second debate, we're going to be looking at the role of liver transplantation for colorectal metastasis. So an interesting topic. We have four contributors here to this one. Richie Manikat, who's the hepatology fellow at Stanford, Michelle Kim, who's the transplant surgery fellow at Stanford, Clifford Akateh, and I'm sorry if I'm mispronouncing that, transplant surgery at Stanford, and then mentored by Tara Ghaziani, our clinical assistant professor of medicine, who was our one of our speakers yesterday in the liver, gave an excellent talk yesterday. So why don't we? So I guess we've got a yes and no. Let's do the same voting if we can for this, and then see if the group can convince us one way or another. Who thinks we should be doing liver transplantation for colorectal metastasis? All right, so about a third to two-thirds. Two-thirds think no, one-third thinks yes, so a little bit more work for those to convince. Who wants to go first? Who's joining us first? Do you guys have slides to pull up, or? Yes. Okay, perfect.
Hello, I'm Michelle Kim, and thank you for the opportunity. I'm going to just introduce the topic very briefly before we get into our heated debate. So, as we all know, the liver is the most common site of colorectal metastasis. 50% of patients with colorectal cancer develop liver mets. And of those 50%, only 20% with colorectal liver mets are considered resectable at the time of presentation. And this is eligibility for resection that's aimed for a cure. However, as adjunct treatments have developed for colorectal liver mets, not just surgery, but evolution of ablation for recurrences or biologics. The line of what is resectable and non-resectable is kind of blurred. So in this schematic, in the green, we have what's most obviously a resectable colorectal liver met patient, where they can be eligible for a resection and be done and cured. There's a gray zone where, back in the olden days, there were very strict criteria for what was deemed resectable. And now the approach is to resect whatever you can as long as there's a functional liver remnant. And for what cannot be resected, we have options of ablation and biologics and other treatments. On the other spectrum of unresectable colorectal liver mets, we have those patients who have high tumor burdens. They have non-resectable extrahepatic disease or right-sided tumors, which would leave not enough liver remnants. And then those with very unfavorable biologies. And so for those patients, what they are candidates for is including a liver transplantation is what we call like the thin red line. And so how we can determine those who may not be candidates for for liver transplant is really the tincture of time, as demonstrated in that schematic. So for those with liver mets that have not metastasized elsewhere, we can treat and wait. And for every 10 people who might be a candidate for a liver transplant, there's tens of thousands who are likely not. And so as we discuss the possibility, this new horizon of liver transplantation for colorectal liver metastases that are not resectable, we just have to remember that this is not meant to be the primary treatment modality for this dilemma, since it maybe only a few rare select patients might be candidates. So as transplant oncology has become more popular in the last couple decades, especially for indications of HCC, cholangiocarcinoma, and neuroendocrine tumors, there's an interest in using transplant for unresectable colorectal liver mets. Early experiences in the 80s and 90s were extremely discouraging due to poor survival and high recurrence rates. And it actually became a contraindication to transplant for colorectal liver mets. But these studies were not set up with strict inclusion criteria. There was no standardization of who was a candidate for a liver transplant. And so Drs. Manikat and Akateh will actually go over these studies that have kind of set the foundation for this debate. So in Norway, where they have more of an abundance of deceased donors, they were able to conduct the SICA trials. The first trial was published in 2013, which had 21 patients who were transplanted with deceased donors between 2006 and 2011, with a median follow-up of 27 months. And their disease-free survival was 35% at 1 year, which is very modest. In 2020, they published a second trial, SICA-2, also a prospective trial with 15 patients transplanted between 2012 and 2016. And in this study, the selection criteria for who they included was much stricter. So these patients had to have a confirmatory PET-CT, which demonstrated no extrahepatic metastatic disease, greater than 1 year time span from their initial diagnosis to their liver transplant, and at least a 10% response in tumor size on chemo. And they had much improved outcomes, including 1 year survival, patient survival of 100%, and disease-free survival of 53% at 1 year. Of note, there was a D arm of the SICA-2 trial where they tried to expand the indications for liver transplant. And they included patients who had synchronous liver mets that developed within a year of their initial diagnosis, and those with pulmonary mets. And that trial was a lot less successful, with a paltry disease-free survival of 4 months. We've actually attempted this in North America in 3 centers, 2 in the US, 1 in Canada, that included 10 patients. And obviously there's a scarcity of deceased donors to use for a prospective study like this. But their patients were actually living donor transplant recipients between 2017 and 2020. And they also had a disease-free survival of 62% at 1.5 years, which exceeded the SICA trials. And so as you're listening to the debates, we just have to balance what the perspectives of the gain for the individuals versus the population. So for the gains, we think about things like survival and just overall benefit, whereas for the whole population, we have to think about scenarios like the waitlist dynamics for organ transplantation. In the US, livers are a scarce social resource, how organ allocation works, and the priorities. And when the answer is not very obvious, which is marked by the appropriate column in that graph, and it's not obviously harmful, it becomes kind of an arbitrary gray zone. And when we're looking at a decision where we're not sure if it benefits the patient and we're not sure if it benefits the overall population, in that arbitrary region, we should look at evidence, which often comes in the form of prospective trials. And so now I'll turn it over to Dr. Manikat, who will present the con argument for using liver transplant for colorectal mets.
Thank you, Dr. Kim. So I'll be discussing the questions that yet remain in this topic that Dr. Kim has introduced. So 3 major points. We don't yet have an ideal patient population that benefits from this procedure. Also, cancer recurrence is a very huge issue that needs to be adequately addressed and has a plan in place before we proceed down this path. Finally, there are some ethical considerations we need to be aware of. This is not Norway. The organ surplus in Norway, as Dr. Kim alluded to, is not what exists in the United States. Secondarily, the patients here are much sicker. The median bilirubin in the study that Dr. Kim mentioned was 2.7, whereas the SICA trials actually excluded patients that had a bilirubin greater than 2 times the upper limit of normal. So our patients here are much sicker. The insurance system, as we all know, is entirely different. Norway is single payer. The referral system is more streamlined. In the United States, there are significantly hurdles that exist in getting the primary treatment addressed, and then, even when they are addressed, they are also more thoroughly treated. Looking at the SICA-2 study that Dr. Kim introduced, we can see that the rate of disease-free survival and no evidence of disease is marked as over 60%. However, even 4 of these patients had pulmonary resection of lung mets even after liver transplantation, leading to the problem of cancer recurrence. In the SICA-2 study, also coming to the problem of patient selection, looking at a Fong clinical risk score, which predicts colorectal cancer recurrence, the survival in those patients is very bleak, as can be seen. Are we going to exclude these patients when we transplant livers for them? Is that ethical? Again, that all needs to be addressed before we proceed down this path. The BRAF V600E mutation also confers very poor survival outcomes in these patients. As you can see, 60 months versus just 11 months. These mutations were not necessarily checked in the SICA-2 trials. Should we check these mutations? And if they are checked, do we then exclude these patients? When our colleagues then looked at the UNOS data for liver transplantation as it currently exists, they reported as 3-year survival of 60%. However, that's for living donor. We're not going to be doing living donor. We're going to be doing deceased donor, which has lower rates of only about 50%. And again, keep in mind, this is 3-year survival rate, not the 5-year 80% that the SICA trials reported. Reporting is key, and also it alludes to the sicker population that we have here in the US. Looking at the study that the living donor transplant study that Dr. Kim had mentioned that was done, one of these patients had positive lymph nodes in the hepatectomy specimen. A lot of these metastases are occult metastases. Up to 40% actually exist at the time of liver transplant. So unless we find those and adequately address those, these patients are destined for cancer recurrence, and you've done a futile procedure. One patient, for example, had recurrence just at 3 months in the transplanted liver of colorectal cancer. Again, our second point is that cancer recurrence needs to have a clear plan. The plan needs to be standardized, so every center nationally will need to have a uniform plan on how these patients are monitored for recurrence, the lung being the primary site of recurrence. In the study that our colleagues performed in the United States of 2 centers in the US and 1 in North America, each of them had different criteria. How are we going to do this in the whole country if even in one trial we have differences in our criteria? They had differences in the BRAF proto-oncogene, they had differences in the CEA levels, they had differences in whether or not they looked at the ASO criteria. Again, we need to stabilize these criteria. Probably a key thing to compare is transplantation better than the current standard of care, which is systemic chemotherapy? Those rates are usually improving over time. The Olivia trial, for example, looked at bevacizumab and FOLFOXIRI, and it found an 80% tumor response rate. 60% of those patients were able to be downstage, and then their tumor could be resected. Is that a better option than doing liver transplants for these patients? It could be. Ethical consideration, as we mentioned. Are we going to put these patients on the national transplant list where they're competing for patients with primary liver disease? Is that ethical? Is that the right thing to do? And if we give them MELD exception points, are we then displacing those patients further? However, if we don't, then the cancer obviously is going to advance. What is the ethical thing to do? We don't yet have answers. Our colleagues have raised the option of living donor transplant, but even those has issues. Is the improvement in mortality enough to justify the risk to the donor? And also, what happens if the graft fails after a living donor? Are we then going to take donors away from the national transplant list? We don't yet have a plan. Basically, my point is going to be that the criteria needs to be standardized and refined. We need to continually compare the outcomes of liver transplant with palliative systemic chemotherapy, which is the current standard of care. And until we do, we need to hold off on it. It's always good to be bold and be forward-thinking. However, we also need to know that we need to walk before we can run. Thank you.
Thank you, Clifford. I hope I can convince you that we should, in fact, be looking at these patients differently than we are. I think the poll area kind of told me that I have my work cut out for me. So I'll be arguing for doing liver transplant for colorectal liver metastases. And Michelle already pointed out the reason we haven't done this is because, back in the early trials, the outcome was pretty dismal. And it makes sense if you have an outcome of 1 year survival of 62% and 5 year 18%, you wouldn't do it. But things have changed. Survival after transplant has changed. The transplant process itself has changed. Kind of going back to the same studies that Dr. Kim already alluded to. Good thing we are all talking about the same studies, so we don't have to repeat them over and over again. I'll go back to the outcome from the CK1 trial, because this is what really kicked this idea of colorectal liver metastasis, liver transplant for colorectal liver metastasis. Look at overall survival on this trial. 95% at 1 year, 68% at 3 years, 60% at 5 years. It's good to take these numbers in context, because at the time of this trial, the overall survival on this patient population on chemotherapy was less than 10% at 5 years. So you're increasing the survival from less than 10% at 5 years to 60% at 5 years. Does it justify the risk? I think it does. I think it justifies doing transplant in this patient population. What about what we already do? We do retransplants, for example, for patients whose graft fail. The survival at 5 years in patients who get retransplanted is 55%. It's less than what we found in this trial. And this trial included all comers, as the previous speakers already showed us. So again, when you dissect the CK1 trial even further, there are a few things that we learned from it. We learned about which patients we should probably think about a little bit more as we've already talked about. Patients with a big cancer, patients whose CEAs are greater than 80, patients who progress on chemotherapy, patients who had a pretty short time between their diagnosis and the transplant. So the CK2 trial took all of that into effect and excluded some of those patients. And without going into details of some of this criteria, I just want to point out the difference in the CK1 and CK2 trial. Again, took in effect the patients who had a high tumor burden, high CEA, patients who had a short time between their diagnosis or their initial surgery and their transplant. And when you do that, you have a 1 year survival of 100%. All these patients at 1 year were alive. You have a 3 year survival of 83%. At 5 years, still 83%. Yes, there is recurrence. The disease-free survival was only 53%, but that did not have any effect on mortality. And who is to say just because the disease recurred means that the transplant did not work? It doesn't, because the patients are still alive and doing well. kind of gloss over these studies in the interest of time. And what kind of lessons did we learn from the SEEKR-2 trial? We learned that patients can have, like I already mentioned, a long overall survival even if they relapse. The other thing that we didn't talk about was in the first trial they were kind of worried about the immunosuppression. They introduced mTOR pretty early, and that we know has increased risk of hepatic artery thrombosis when you start mTOR within 30 days from your transplant. So in the second transplant, they waited and they used a more standard immunosuppression regimen, which introduced mTOR after 30 days. And they did not see the same incidence of hepatic artery thrombosis, which kind of also improves the outcomes that we found from the SEEKR-2 trial. And without going into details, there was another European multi-center trial, a little bit different from Oslo, where, as Dr. Manikat argued, they have a surplus of organs. Again, really amazing outcomes, 83% one-year survival. What about the United States? We know that since the initial SEEKR-1 trials, the rates of transplant has been increasing. And patients are looking for this. Patients are traveling all over. They're going to centers that are doing these transplants and asking for these transplants. So we have to listen to our patients. They are asking for it. What is the overall survival when you look at the US data? If you look at all comers, the one-year overall survival is 89%, at 3 years, 60%. And if you look at living donor transplant, like we already mentioned, 100% at 1 year. The deceased donor is 77%. That's because they're using discarded grafts. So patients that are getting transplanted in the US are using grafts that nobody else will use. And even those patients have a 77.1% survival at 3 years. At 1 year, 50% at 3 years. And the interesting thing is if you compare these patients to other cancers, right? We already do transplant for ACC. We already do transplant for intrahepatic cholangiocarcinoma. If you compare the outcomes in these patients, there's no difference. So you could say, is it ethical to transplant these patients? Well, is it ethical to transplant the ACC patient or the cholangiocarcinoma patient? They have the same outcomes. So why wouldn't you transplant the patient who has colorectal liver mets? And kind of going back at our transplant system, so it's always good to look at these numbers in context. When you look at all comers, this is just data I pulled out from UNOS, and you can get these reports from UNOS, the publicly available data. At 1 year, primary transplant, only 91% survival. If you do a repeat transplant, it's 81%. And you have the numbers at 3 years and at 5 years. So the data that I'm showing you from the US and the SEEKR-1 trials, pretty comparable to what we already have. So why would you exclude the patients who have colorectal metastases? Again, what about the shortage of organs? Dr. Manikat said there's a shortage of organs, therefore we shouldn't use it. We've never used that as an argument to any of the other groups. We don't tell patients with ACC there's a shortage of organs, therefore we won't put you on the transplant list, right? So why should we tell the patients who have colorectal liver metastases? The other interesting thing is we know that we're using more and more grafts. Yes, there is still a shortage of grafts, but we're using more marginal grafts. Dr. Sasaki yesterday presented on machine perfusion of organs and improving use of allografts when we perfuse these organs. This is supposed to say hepatitis C, not ACC, but hepatitis C is treatable, thanks to many of you in this room. And that used to be the biggest chunk of patients that need a transplant. So there's a group of patients who are getting removed from that list, the patients that have hepatitis C. We probably need to add some other patients to that list. In this case, they're patients with colorectal liver metastases. I'm just going to end by talking a little bit more about the two different populations. If you have a patient, high degree burden or high disease burden, but otherwise relatively normal liver function, you can give that patient a living donor. If you have a patient who has a high melt already, even if their disease burden is not high, these patients can get a deceased donor just based solely on their melt. So why wouldn't you do that? And I agree with Dr. Manikat that we are not there yet. We have to figure out who is the best patient to get transplanted. Not all ACC patients get transplanted. There's a Milan criteria, right? So we have to establish criteria for this patient population as well. The biggest struggle we have is that we don't even have a registry. I think that's kind of where we need to start, collecting this patient, making a registry, and studying and seeing who is the patient that benefits most from this patient population, instead of saying, no, we shouldn't do it. And I'm just going to end with this quote from J.C. Newman, one of the bishops from the UK. It's an old quote. It says, nothing will be done if we waited to do it so well that no one finds fault. So just because the system is not perfect doesn't mean we shouldn't do it. Thank you.
Any other comments from anyone? Oh, yeah, if you, oh, sure, go ahead, yeah, go ahead, yeah, go ahead, go ahead.
Well, thank you so much for presenting all the data. Well, I'm supposed to be Team Richie and argue against, the indication for, transplanting for colorectal mets, but I don't want to make you confused. I'm actually in favor of the other team, and I'm going to, yeah. So, because I think yesterday we had a couple of talks that set the stage for this talk today. We heard about how the transplant field really looking at the indications of transplant totally different way in the past couple of years, where Dr. Kwong showed that we're transplanting patients with acute alcohol-associated liver disease. Right, this was not an indication like just even a couple of years ago. So we're transplanting those people. And, she showed that, some centers are actually transplanting like up to 50% of their cases just for alcohol. So that's a different theme now in the transplant field. We talked about intrahepatic cholangiocarcinoma, a disease that never was considered for transplant yesterday. And Dr. Sasaki also set the stage about using some of the marginal livers for indications that are not straightforward. Maybe we can use those, and that's how we can expand, the transplant oncology field, basically. So cancer is one of the fast-growing indication for, transplant field, and same as for colorectal. I think we're at the time that we have enough data showing that yes, there is excellent outcome doing transplant for selected patients with colorectal mets. Even the SICA-1 trial, which was, 2013, if you look at I don't know if you showed that, the 10-year data follow-up, 50% of these unresectable patients with a lot of, mets in the liver, 50% of them still alive. That's huge for, patients with really metastatic colon cancer. And then that's how they came up with the Oslo score, and then that shows how biology is important in selecting. So we're not saying this should not be an indication. We're just saying that, okay, the selection criteria is very important, and biology really plays an important factor. And then we talked about recurrence problem. Yes, there is recurrence, but if you notice that recurrence happen mainly in the lungs, and if you take care of these metastatic patients, recurrence of the tumor in the lungs is not as bad as recurrence in the liver. These patients can get local therapy for lung lesions. That is not impacting their survival as opposed to the recurrence in the liver and eventually liver failure. So that's the point we should pay attention in colorectal mets. And then using the marginal liver, obviously, with the perfusion pump, we're probably not going to expose patients or outcome of program using those livers for patients that they will benefit from having a curative therapy and expand their survival. So we're in favor of the colorectal mets transplant.
Let's see what the audience. All right. Any changes here? Anybody changing their mind? No? No? Well, maybe a little bit. All right. That's pretty good. All right. Good job, guys. Thank you very much. Appreciate it. All right. So let's move on into debates. So the next debate is a great one. What's the best option for sleeve gastrectomy for the obese patient? Do we want to do this laparoscopically or endoscopically? joined here by Dr. Jordan Taylor, who is a clinical instructor, having finished his general surgery fellowship, and is currently an esophagus fellow with plans for minimally invasive surgery fellowship. And then Dr. Brian Ruhle, bariatric surgery fellow currently at Stanford. So let's start with the poll here. Thanks for that. So what is the best option for sleeve gastrectomy, endoscopic or laparoscopic? Got a bunch of GIs in the audience here.
Or one person.
Yeah, there you go. Okay. That sounds good. All right, who's starting here? You guys.
I'm going to go first. Good afternoon, everyone. My name is Brian. I'm the bariatric MIS surgery fellow at Stanford. And so I'm going to defend why lap sleeve is superior to the endoscopic sleeve gastroplasty. And I'd actually say that it's not only superior to the endoscopic sleeve, but it's also probably the best bariatric operation that we have, both in the US and worldwide. So the lap sleeve as a standalone primary bariatric operation was first introduced in 2003. And then within 10 years, it surpassed not only the adjustable gastric band, but also the Roux-en-Y gastric bypass in the United States, and remains the most popular operation that we perform in the United States. And this trend isn't true just here, but this is also true worldwide. This is data from the IFSO from 2022, showing that 67% of primary bariatric operations are lap sleeves. Most of these are done laparoscopic, a couple of them robotic, very few right now endoscopic. So why is that? Because the lap sleeve we know works. We know that it produces substantial as well as sustainable weight loss. And we have both randomized control trials that show this, as well as observational studies. The two big randomized control trials for the lap sleeve were the Sleeve Pass trial in Finland and then the BOSS trial in Switzerland. Both of these randomized patients with BMIs 35 to 60 to either a lap sleeve or gastric bypass. And we now have 10-year data from these trials. This is a combined analysis of those two studies, looking at those weight loss outcomes. And what you can see is that after 1 year, the total percent weight loss after a lap sleeve was about 28%. And this was sustained. Here it's at 5 years, about 24%. So how does that compare to the endoscopic sleeve? So the best study that we have for ESG comes from the MERIT trial, which is also a multi-center randomized controlled trial that was done here in the United States. This looked at patients with BMIs 30 to 40 and randomized them to either an endoscopic sleeve or moderate intensity lifestyle therapy. And they followed them up to 52 weeks. Those patients that were in the control arm were then offered the option to cross over to the endoscopic sleeve if they didn't sustain enough weight loss. And what we see is after 52 weeks, the total percent weight loss was at 13.6%. So about half of what we saw with the lap sleeve. So we don't have any head-to-head lap sleeve versus ESG data, but we do have some observational retrospective studies that compared the two. And these numbers are pretty similar. The total percent weight loss after the ESG, after 12 months to 24 months, was roughly similar, a little bit higher in these groups. The one on the left is a study from Spain. The one here on the right is from Cornell, but about 18% total weight loss after an endoscopic sleeve gastrectomy. Again, 28% after a lap sleeve. So I'd say in terms of total percent weight loss, lap sleeve beats ESG, but it does more than that too. It also addresses medical comorbidities, and we know this from multiple studies. The Stampede, looking at patients with diabetes and obesity, about 50% had improvement or resolution in their diabetes. So how does the ESG compare? So I think Jordan's going to present this study as well, but this was a single center study from Saudi Arabia looking at comorbidity resolution or improvement after ESG. What they are sort of misleading but telling you here is that they had 100% improvement or resolution in type 2 diabetes, hypertension, and hyperlipidemia. But this was the largest single center series. They had 1,000 patients, and if you put it to scale, this is 3% of their study cohort. So they're looking at a different patient population. And I'd say that we're not even really comparing apples to oranges, but probably apples to the apple tree, in the sense that anything that the ESG can do, the LSG can do better. So If we were to look at similar cohorts, and this is what this study aimed to do, this was done in Hopkins, but this was a propensity score analysis. So they matched on demographics, on baseline BMI, on presence of comorbidities. What they saw was similar improvements in these comorbidities between the two groups. But where I see from this data where ESG really starts to fail is for those higher BMI patients. So after, for patients with a BMI 40 or more, we're not seeing the same results with an ESG. They're not getting that same amount of weight loss. And so they're probably also not getting the same amount of improvement in their comorbidities. Now, what this group also sort of highlights is that after an ESG, these 23 patients, none of them went on to develop GERD, whereas 7 patients after a lapsed sleeve had GERD. So that's about 30%. We know that reflux after a lapsed sleeve is a real problem, and the prevalence is probably around 30%. When we were first looking at lapsed sleeves, people were saying 2% risk of GERD, and then 5 years later, 10%, and now 30%. So I do think we were underreporting that at the beginning of the lapsed sleeve, and we're probably doing the same thing with the ESG right now. The mechanism for GERD after sleep is pretty complex, certainly multifactorial. But one thing that we've learned from our experience with the lapsed sleeve is that the shape of the sleeve does matter. And so this was a radiographic study that looked at the shape of a sleeve and correlated it with risk of GERD post-op up to, I think, 18 months for this study. But they categorized the sleeve as either having a tubular shape, a dumbbell shape, a lower pouch shape with a larger antrum, or an upper pouch shape with a retained fundus. And what they found was that although the minority of patients ended up with an upper pouch or a larger fundus after their sleeve, those patients went on to have higher GERD HRQL scores, so had worse GERD symptoms. So we know that the fundus contributes to the development of post-op GERD. And I bring that up because if we look at how we're constructing our ESGs, a lot of endoscopists are leaving the fundus, saying that we're preserving the anti-reflux mechanism. Also, this is the more challenging part of the ESG, to be able to placate that fundus. And now we're saying that they have a 1% risk of developing GERD after that procedure. It seems a little bit like we don't have quite enough data right now to make that claim. As far as safety profile, I do think that the LSG and ESG are probably comparable. This is a large database study, so this is MBSA-equipped data over a 5-year period, and there was really no difference in major adverse event between ESG and lapsed sleeve. What was interesting was that the ESG group did have a slightly higher rate of readmission, mostly due to PO intolerance. They also had a slightly higher rate of intervention, usually with endoscopy. They also had a higher rate of operation compared to a reoperation for the lapsed sleeve. But again, these are all really low numbers, and so I may say that this part is actually a toss. What was interesting from this study here is the numbers. So ESG, about 6,000 patients over the 5-year period. Lapsed sleeve, 600,000 patients, so 100-fold more. And who are doing these operations or these procedures? And I think the last point of my argument is with our ability to train both gastroenterologists and surgeons to do these operations. So the learning curves are probably similar. These are both single operator learning curves. On the left for the ESG, it takes about 30 or so cases to get efficient in terms of reducing your procedure time, and about 55 cases to become a master of an ESG, which is similar to what we see with the lapsed sleeve. But if I think about my fellowship training and what was even discussed last month at SAGES, how many trainees, how many fellows are getting these numbers as part of their training? And I'd say very few are actually seeing this number of ESGs, either from the GI perspective or from the surgery perspective. So we're not training enough providers to be comfortable or I'd say proficient enough to offer this more widespread. So I'd say that the LSG beats out the ESG probably in most of the important categories right here. So with that, I'll pass it off to Jordan.
All right, good afternoon. My name is Jordan Taylor. I'm one of the clinical instructors in general surgery and the current esophageal fellow. And I have no disclosures, and I did not use ChatGPT for this presentation. So our objectives today, of course, give you a little bit of historical context and then talk mostly about the ESG, because I think we can all agree that Brian did a great job of presenting the laparoscopic sleeve data. We'll touch on the techniques, and I'll highlight some of the benefits of the ESG, the outcomes, and the safety, which I think is probably the biggest reason why ESG is a better option for our patients. So this is by no means a comprehensive list of sort of the evolution of surgical procedures for weight loss, but of course we started with some of the intestinal bypass in the 1950s, open gastric bypass, open sleeve in the 1970s and 1990s, and then the laparoscopic sleeve in the early 2000s. The endoscopic sleeve is something that's relatively new, so certainly the numbers are less easy to find, and some of the data is still coming out. So that's certainly one of the reasons why it hasn't been as widely accepted. Bury the sleeve, of course, is very popular. As Brian pointed out, the sleeve gastrectomy is the most common, most popular procedure for weight loss in the United States and worldwide as well now. But I don't think that it necessarily is going to stay that way. And we'll talk about some of the reasons why I think the endoscopic sleeve gastroplasty does provide the benefits that you're looking for weight loss, as well as the safety profile that's better. So just touching on the technique a little bit, this is an incisionless outpatient procedure, same day going home, which is very different from the sleeve. But it does reproduce a lot of the same effects. So your goal here is to reduce the stomach size by about 70%. It also reduces not just the lumen of the stomach, but also the length of it by about 30%. What you see them doing here in this animation is they're marking the stomach so that you can then use your suturing device and bring together sort of the anterior and posterior walls, starting just beyond the incisura and going up to and including the fundus if possible. There's a variety of techniques that have been used and studied to look at the suture pattern and see what works best in terms of plicating the stomach. The most common is sort of the one up on the top right there, where it's essentially a running U or a V pattern of stitches. This is just the photos of what it looks like before on the far left there, immediately after the endoscopic sleeve gastroplasty, and then 3 months later. I think everyone would agree that's a pretty remarkable difference and a good result in terms of what you're expecting for weight loss. So how does it work? How are the outcomes for ESG? And in the studies, one of which Brian mentioned, the weight loss is significant. In the early term, 1, 3, and 6 months, their weight loss continues to increase when you're looking at the total body weight loss approaching 15%. The largest primary study of patients undergoing ESG is this 1,000 patient consecutive patients, and they similarly had a good amount of weight loss at 6, 12, and 18 months as well. And they did also show an improvement in the comorbidities. And as Brian mentioned, significant improvement in diabetes, hypertension, and hyperlipidemia, all of which was actually within the first 3 months of the procedure. Looking at the other outcomes, multi-center studies, again, about 250 patients, looking longer term now at up to 24 months, you're seeing still a durable response of about 18% weight loss. Some of these studies also not showing yet a plateau in weight loss, so longer term studies are still being done. And again, significant reduction in some of the comorbidities, so in A1C and systolic blood pressure, triglycerides, and LFTs. Safety, and this is probably the biggest difference. And safety is something that leans, I would say, in favor of the ESG versus the laparoscopic sleeve. And again, that largest study with 1,000 primary patients, the biggest complaint was nausea within the first week. They did have a pretty high ED visit rate of about 21%, though their protocol was designed to have a very low threshold for bringing patients back as they were just starting out with this. So despite 20% returning to the emergency department, their readmission rate was about 2.5%. Most of those patients ended up just needing to be observed. Very low rates of any blood transfusions or intra-abdominal collections. In Lopez Naval, both a 6-month and a 24-month follow-up, very low rates of serious adverse events. So comparing the safety, I think when we look at, this is from 2 systematic reviews and meta-analysis from both 2014 and 2017 that looked at the laparoscopic sleeve, the complication rates are higher, at around an average of 13% for complications overall, reoperation risk about 9%, and then some of the other complications listed there. There's a few studies that have looked at a single institution to see in their own hands, what is the difference in terms of outcomes as well as adverse events. And so this single institution saw, about 90 ESGs and 120 lap sleeves in the time period, and saw that the adverse event at the institution was significantly lower in the endoscopic sleeve compared to the laparoscopic sleeve gastrectomy group. The length of stay is significantly shorter, and readmission rate was shorter in the ESG group, but not statistically so. As mentioned, GERD after laparoscopic sleeve gastrectomy is pretty common. This is certainly a complex topic. It's not just that everyone gets GERD immediately. There's a time component to it. There's a component that has to do with the variability in how the sleeves are created. But that's a pretty high number of patients that are getting reflux after a sleeve gastrectomy. Whereas there is growing evidence that the endoscopic sleeve is a lower pressure system and doesn't have the same incidence. So in this one study, they compared again ESG to laparoscopic sleeve gastrectomy, and the new onset of GERD was under 2% in the endoscopic sleeve group. So in conclusion, I think this is the better value. So it's not entirely just about that single number of better weight loss performance with the sleeve gastrectomy versus the endoscopic sleeve. There's a cost that's associated with the complications. There's a cost that's associated with the inpatient stays and the complications that come after a sleeve gastrectomy as well. The other difference, though, the endoscopic sleeve gastroplasty is reproducing the same contour and size of the stomach. It also is something that maintains the anatomic structure. It doesn't disrupt the innervation or the blood supply to the stomach. It's something that can be repeated. There's studies that have looked at patients having repeat procedures. It's reversible, and it is convertible to traditional laparoscopic or traditional bariatric procedures if needed. The ASMBS put out some guidelines for any endoluminal procedures and what sort of criteria they should look for. So weight loss, as we mentioned, certainly 15 to 20% total body weight loss is expected with endoscopic sleeve. Safety, and I would say definitely better profile for the ESG. The efficacy, that it does also improve comorbidities. I'd say that more data is still needed to give a better full description of how much it does. And then the durability, at least in the current studies that we have up to 24 months, this is a durable thing. And then as a bonus, I guess, what we've seen as well is that if you do gain back weight after your laparoscopic sleeve gastrectomy, you can still have a sleeve gastroplasty, and you get a pretty good response with weight loss of about 18% at 6 months and 70% at 1 year. So, thank you.
What do we have? We have 80, is that what it was at the beginning?
Might have lost some.
20 surgeons and 80 gastroenterologists in the room. All right. Stayed stable. Great. So we got one more debate. For the final debate, this debate is titled Horizons for Effective Microbial Therapeutics for GI Disease, Which Therapies, Which Disease? I have the pleasure of reintroducing Sean Spencer, whom we heard about earlier, who was a fantastic instructor in gastroenterology and hepatology with great work in dietary influence on the microbiome. And then the pleasure of introducing Alice Cheng, who's a clinical assistant professor and has done excellent work in microbial communities. So we have a little bit of a different poll here. This is a little bit more work on you guys' part. But so the question here is, what is going to be the next FDA-approved indication after C. diff for a microbial therapeutic? And so this is open for you to type some responses in the word cloud, and then we'll see some things pop up here in the word cloud. So hopefully the typing fingers are still working. All never seen these evolve. These are pretty cool. I feel like we can just keep this going all night, but let's see. It looks like pouchitis and IBS sort of got the most popular. Let's see if we change that at the end. We'll reassess. Thanks, Ron.
All right. Hello again, everyone. We're not doing as much of a debate. We didn't feel like this was an incredibly controversial topic. We didn't want to build any straw people that we would artificially destroy afterwards. So we're going to do a bit of a tag team here, and hopefully, as we saw, the debate at the end should hopefully be what is the next indication after C. diff for a microbial therapeutic. So you saw this slide earlier. We have tons of bugs inside of us. They have a lot of genes and they do amazing things. And I wanted to, in this talk to you a little bit about why now, why the recent advances. And this is two reasons. The first is sequencing technology. We can now quickly and relatively cheaply sequence all of the DNA in our stool and anywhere in our GI tract. And this helped us understand and really define what was there. And this is something that took place over the last 10 to 15 years, very recent. This was simultaneous with understanding what was there, but also how to grow it. So we can now culture almost all known organisms, and I should put a caveat, in the human GI tract, not the soil is still pretty challenging. And Dr. Cheng has really mastered this art and has assembled a large synthetic community of 118 of these bugs using kind of next generation culturing technology. So these two in combination have really propelled us forward. As I said earlier, the problem in the microbiome present in GI disease is that we have an excess of microbes that really are not beneficial to us, and we have decrease in the beneficial organisms, and this leads to a dysbiosis. This loss of key beneficial functions from good bugs and increased harmful effects from bad bugs causes issues. I propose 3 therapeutic approaches, and really the one that we'll focus on today is giving the good bugs back in the context of a microbial therapeutic. There are currently available microbial therapeutics, ones that we know well and are widely used, and those are in the form of nutritional supplements, also known as current probiotics. Want to continue to highlight these lack strong scientific backing. They don't have data supporting their efficacy. There is an intermediate category known as a medical food. This is not quite FDA approval, but they are able to make limited claims. And the important thing here is that they're compositionally defined. And by being a medical food, they actually verify what is in the bottle. And then where we're headed is in FDA approved LBP. This is an abbreviation for a live biotherapeutic product. This is the category in which the FDA has chosen to regulate live therapeutics. So this category also includes gene therapy, CAR Ts, and will include microbial therapeutics. They should have a specific disease indication, highly defined product, and a rigorous phase 3 randomized control trial in that disease indication. Really, the promise here is that the current probiotics of Bifidobacterium and Lactobacillus really represent a minor proportion of what is inside of our guts, and almost the full component of the human microbiota remains untested clinically outside of fecal microbiota transplant trials. In terms of compositional definition and based in human biology and disease mechanism, you see current for example, VSL3 is highly defined, but really not native to our biology, whereas FMT is poorly defined, but based in our human biology and disease mechanism. Where we would like to end up is being highly defined, highly tested, and based in human biology, which is a place we'll get to soon. And then I'll turn over to Dr. Cheng for the remainder of the introduction.
All right. Okay, so picking up from Sean, and as excellent introduction, I'm going to actually focus further on FMT, which is still the substrate of use in many of our current clinical trials and therapies. And which we've used extensively still in the discovery and treatment of microbiota-associated disease. So with FMT, just to delve further into it as a substrate, it was actually developed a while ago in ancient China, but as far as currently, it was just approved in 2013 for administration for recurrent C. diff under auspices of clinical trial, and that is currently the standard of care for recurrent C. diff. And there's 3 caveats I'd like to point out with respect to FMT. One is actually the mode of delivery quite matters, where there are several analyses, all combined in this 2017 analyses, showing that there's actually colonoscopy administration of FMT exceeds effectiveness of EGD administration, and that pill capsules are relatively equivalent to colonoscopy and enemas equivalent to EGD. So mode of delivery very much matters. And 2 is that more recently, some widely publicized trials in 2019 showed that FMT could be a vector for pathogens or pathobionts, where ESBL E. coli can be conferred in donor stool. And then further combined with the issue of COVID being delivered in the gut in 2020 with the COVID epidemic, this has given rise to new FDA restrictions on donor stool screening and has restricted actually FMT administration significantly. And further, that efficacy can be very variable for anything else except C. difficile. And so to move away from this, the new kid on the block actually surmounts some of these challenges with FMT because as of last year, the FDA has approved Rebiota as a substitute for FMT. It's a microbiome-derived therapy. Really, it means that it's like a stool-derived substrate from healthy human donors and contains at least 200 viable species, at least per their website. And it has been screened for all pathogens that are known. And that in a series of RCTs, multi-center RCTs, double-blinded, they have shown that there's at least a 70% efficacy for cure of C. difficile compared to placebo. And furthermore, that Rebiota, the mixture, stably confers healthful strains or like standard gut strains and the Bacteroides and Clostridia genera and order that are found in usual human guts for at least 2 years post-transplant. So all of this, I'd say, is quite good in considering that Rebiota is actually given as a single enema as therapy for recurrent C. diff. So patients can give it to themselves if prescribed, basically. So, but returning to FMT, it's still very much in use as a therapeutic and trial substrate. Showing here is the immense interest from the basic and clinical side, research side, and using FMT as substrate. As you can see on the top graph, there's just successively increasing number of trials that utilize FMT over the years, and that they are chasing after all manner of conditions that are not just C. diff, and of which we will discuss in the further slides. And then, just to give another small glimpse into the horizon, this is the next step. So what Sean had alluded to about the next live microbial therapeutics are here. So Ceres and Vedanta are perhaps the forefront companies, and they are bringing defined, simplified microbial consortia into the clinic soon, hopefully. And these are consortia of 8 to 10 organisms, of which you can control the abundance and presence. So you control potency and purity. And as you can see, they're not just trying to treat C. diff, although that is their usual first trial, but seeking to address other things listed as such IBD, pouchitis, and more. And I'd also like to bring your attention to the other kids on the block, including like Shielta and Federation Bio, which are focusing on engineering like single organisms to have immunomodulatory properties as well as larger consortia for use as therapy. But all this is just a preface to our debate as far as which diseases might be amenable to these, to FMT and to these new therapeutics that are upcoming. So I'll turn it back to Sean.
All right, so we'll start with the lowest hanging fruit of C. diff. And we have a bit of an outline for how we'll go through this. We'll first describe the rationale for FMT, the microbiota contribution to pathogenesis. And in C. diff, there's a very clear increase in organisms that are acting in a negative fashion, particularly the Enterobacteriaceae. And there's a broad decrease in beneficial organisms and really a decrease in microbial diversity. And mechanistically, how we think that the microbiota is contributing to pathogenesis is a lack of secondary bile acids. And these are bile acids that are processed exclusively by microbes, largely in the colon, and they directly inhibit C. diff germination and toxin production. So if you have abundant secondary bile acids, C. diff is not able to germinate or produce toxin. And in trials of FMT, so there are 8 RCTs of FMT, and really, it has a significant rate of efficacy. And the other thing I wanted to talk about is, as Dr. Cheng alluded to, is the trial of Rebiota is now FDA approved. And then the other stool-derived product, SEER-109, there was a nice New England Journal of Medicine paper published last year with positive results, and an FDA decision on it is expected April 24th, and it's widely expected to be approved at this point and should be available shortly after. Of note, this is a swallowed capsule rather than an enema and can be delivered at home. Vedanta has a assembled simplified community of 8 strains that's actually recruiting, I think, for a phase 3. Their phase 2 data looked very promising. So C. diff already in clinic, so we think this will continue to be very amenable to microbiota-targeted therapeutics. Next, IBD, something that we've heard about throughout the day, the FMT trials. What's the rationale? So there is, again, you see this bad actor, Enterobacteriaceae, Enterococcus and Streptococci are up. Beneficial bugs, the fecal bacterium, Provotella, and Ocelobacter are down. And again, you see a decreased microbiota diversity. And here the microbiota contribution to pathogenesis, you are lacking beneficial functions of the good bugs. And that is decreased production of short-chain fatty acids, decreased secondary bile acids, and decreased fiber-degrading capacity, as I mentioned this morning. And so the pooled data from randomized controlled trials looks promising. These were either placebo-controlled and most typically in the context of standard of care. You can see that they do offer some efficacy in inducing remission, and when paired with diet, as we mentioned a couple times today, was able to induce deep remission in mild disease. One of the principal limitations of comparing these studies is that there's a wide variety of delivery and also of the substrates. These aren't standardized therapies just yet. And this is a key target area for the development of FDA-approved therapeutics after C. diff. So Vedanta and Series have unique tailored communities, specifically in the setting of IBD, that are actively enrolling. I think Vedanta is at a phase 2. They've established safety, and Series is still enrolling in a phase 1, 2 to assess safety of this community. So active area of research. So I'm going to say this is promising, if not likely, and the data in ulcerative colitis, particularly mild ulcerative colitis, does seem stronger than in Crohn's at this point. Thirdly, and the last one I'm going to talk about is IBS. IBS is a tricky one. There's no consistent microbiome signature across all IBS subtypes. Some studies do report microbiota alterations, but they're not consistent across. One thing that does seem to be consistent is an alteration in the small intestinal microbiome. So this may be a setting in which we need to think about the microbiome of the small intestine rather than the colon and its representation in the feces. Most studies do report decreased microbiome diversity and, again, increased pathobionts such as Enterobacteriaceae, which seem to be a very common player. Mechanistically, in IBS, there are lower levels of short-chain fatty acid production, suggesting that although the community may not be changed, its functionality in producing short-chain fatty acids is decreased. And here, the subsets of IBS do seem to be very important in terms of microbiota signature. IBS with a diarrhea predominance seems to functionally have more hydrogen sulfide production that is thought to actually drive the diarrheal process. And IBS with constipation predominance does seem to be in excess of methane production. And mechanistically, the thought is that methane may actually slow colonic transit and be contributing to a reinforcement of this ecology of slow colonic transit and constipation. Finally, there was a report recently that some forms of visceral hypersensitivity within IBS have a histamine-producing Klebsiella that can actually directly promote hypersensitivity via microbe-directed process. So the trials of FMT have not been very successful. Only 4 of them have a signal, and the signal that has existed is small. If you remember, there was a bit of a splash with a paper that was published in Gastroenterology recently looking at a 3-year follow-up on a trial, and this was all IBS. And they had a duodenal installation of FMT, and this is important because they're effectively and potentially altering the small intestinal microbiome here. It did see a pretty significant signal at 3 years. However, there was a companion perspective written by Michael Camilleri that was pretty hard on it, that stressed that it was not blinded. It had significant dropouts. It had, in his view, a small effect size and a weak microbiome signature in responders. So, and there are no planned trials for advanced microbial therapeutics. I'm going to say possible, maybe IBS-D more likely than IBS-C, but hard to say. All right. Dr. Cheng.
All right, so looking into the liver conditions, well, these are a little bit less tested, but still promising. So I'm starting from the best to the worst. With HE, hepatic encephalopathy, there is significant basic science support in terms of microbiota, modulating the microbiota. There's a signature, and in addition, there's a defined mechanism, or accepted mechanism, of microbiota metabolites mediating neurotoxicity, and not just relegated to ammonia, but maybe other GABA and GABA-derived metabolites. And that the clinical trials, well, there are 2, but they are very promising, given that there's a 2020 open label RCT and also a treatment trial in 2022. And so at the open label RCT, 20 patients with HE were given either FMT versus standard rifaximin lactulose, and that the FMT arm patients significantly had improved cognition as well as prevention of recurrence of HE by 60% reduction. And so given the promising nature of this data, Vedanta has actually tried, is currently undergoing a randomized controlled trial studying one of their consortia to treat HE patients. So I'd give it actually a promising amongst all the liver diseases being addressed. With alcohol liver disease, there is actually also a very strong basic microbiota signature, enrichment of fungal Candida species as well as some bacteria, fusobacteria. And so it's thought that the fungal and bacterial antigens increase hepatic inflammation and injury in context of alcohol use. So, and here are the trials. There are not many again, but again, there is some signal. So in 2018, a treatment trial comparing all the 4 modalities of treatment in 51 ALCUP patients showed that actually FMT had the best effect on survival at 3 months, because those patients are at 75% survival compared to 20s and 30s in the rest of the treatment arms. And then furthermore, an RCT RCT that was double-blinded in 2021 showed significant reduction in the FMT arm in terms of alcohol cravings and hospitalizations for alcohol use, a reduction of about 60%. So with that, I'd say promising, and that there are currently recruiting trials, recruiting as well. As far as PSC, so going down the line, there again is basic science a signature. So microbiota changes that are consistently present with PSC patients, and it's thought that immunomodulation and increased bile acid pool hydrophobicity has a hepatotoxic and cholangiocyte toxic effect and may lead the way to sclerosis. But the trials are pretty meager. There's just been one out, and it showed basically it was a treatment study applying FMT to PSC patients. And in some of them, they were able to achieve a 50% decrease in alk phos, and it was safe to administer, but the outcomes remain to be seen. So possible, maybe, and the more trials are needed. And as far as NAFLD, it is a complicated disease and with a complicated etiology. And so many potential microbiota associations and pathways to disease. So there is increased streptococcus and Bacteroides species, it seems, and that leads ultimately to a lot of microbial metabolite-driven hepatotoxicities and fibrosis activations. But suffice to say, the clinical data is quite, a lot of effort has been made, but not too much signal has come out. So here in 2020, there were 2 RCTs that were done comparing FMT of a patient's own stool versus allogenic outside donor stool in NAFLD patients. But in either one, there was no significant change in histopathology after 6-month follow-up. And then in 2022, a more promising open-label RCT showed that in comparing administration of FMT versus probiotic, maybe there's a beginning signal in lean NAFLD patients in achieving decreased fat deposition signal on FibroTouch. But again, I'd say clinical data is still lacking. More studies are needed. And then finally, with chronic HBV e-antigen positive, I thought this was actually quite surprising because there's a beautiful basic science mechanism where increased levels of Enterobacteriaceae and Faecalibacterium species seem to exert immunomodulatory effects on the host, such that it decreases the host's ability to clear e-antigen. And the clinical trials were really, I thought, astounding. In 2017, an open-label RCT comparing FMT to standard antivirals actually showed that FMT significantly reduced e-antigen in the treatment arm, and that it's cleared e-antigen in 3 of the treatment patients. It was an equally, so 9 and 9 treatment versus control, and shown there is the reduction in e-antigen within this patient population. And again, this was the finding was repeated in an open-label trial in 2022. But in both cases, there's no seroconversion and no clearance of HPV DNA. So while it's really promising, I'd say, the end game is to clear the HPV, which it did not. So a little more work needs to be done. But with all of those studies, we'd like to conclude with some of our questions that we've already gone through. Namely, I think we'll run the repeat trial, that poll about which diseases may be amenable, but just some more food for thought. In terms of, will there be common therapeutic microbes in FMT trials in the future? And then as far as delivery mode, as we saw, it is important for FMT, but what about these other live microbial therapeutics coming around the block? And then finally, will we maximize benefit by pairing the microbial therapeutics with dietary modifications? All remains to be seen. So with that, thank you all. That's it.